Assalamu alaikum. Thank you so much for inviting me. The topic of my presentation today is the novel treatment of atopic dermatitis in children. And of course, the motivation behind this lecture was Madam Yasmina, and she has always motivated us and encouraged us to talk about children, which is the need of the day as well. So moving on to the next slide. And there is no conflict of interest to declare. We are all familiar with the current therapies for atopic dermatology, and I would like to give a brief overview of those as well, along with the brief overview of the disease. And then we will move on forward to the newer therapies, which are emerging therapies all over the world, and some of them are also available in our country. Now, what is atopic dermatitis? As we are all familiar, it is a chronic relapsing disorder. It affects the lives of many children as well as their parents, and it becomes very problematic in most cases. It can move on to be from acute to subacute as well as chronic. It may also affect the normal growth of children. The prevalence has increased over this century, and it is difficult to manage mostly. We have around 20% of the children who are affected by atopic dermatitis, and 45% of these have a rash in the first 6 months of their life, and more than 60% develop the full-blown disease at about 1 year of age. So this is obviously something which we need to dig into and find newer ways of controlling this problem. And the children also have a family history which increases by the first or second degree relative who are affected. Now, the pathogenesis is obviously very complex, but we all know that there is a defect in the epidermal barrier, and the filaggrin is important in this aspect, which is defective. And this epidermal barrier is further affected by environmental agents as well. There's a genetic background, and this leads to the release of various interleukins. These interleukins then activate the dendritic cells, the Langerhans cells. These all result in a cascade of release of many cytokines and reactive proteins with the activation of T helper cells as well. And in the acute stage and in the chronic stage both, we have the activity of these cells, which is an ongoing process, and then we get the signs and symptoms of the disorder. I'm not going into the detail because the topic is for the treatment. Now, a brief overview of the current therapies which are available. As we all know, we have a range of steroids ranging from mild, moderate to potent and ultra-potent, and we keep on trying to decrease the inflammation and the symptoms by these steroids. Just like Madam said, that we keep on juggling between beta-derm, clobiderm, but we have other topical options as well. The second steroid-sparing therapy which we have is calcineurin inhibitors. There are two of which are available. There is tacrolimus and pimcrolimus, and we should try to prefer these over steroids, especially over the areas when there is thinning of the skin. Then we have phototherapy as well. This is the patient of my own picture of my own patient. And she was having phototherapy, and now she's on various therapies now, but still her disease is not controlled. We'll move on to it. Anyways, UVB and UVA both are options which are available with us currently. Then we have systemic immune modulators as well. We have azathioprine, mycophenolate mofetil, but they have a varied side effects, which you can see ranging from mild side effects, common side effects like lightheadedness, or severe side effects, for example, neutropenia and pancytopenia and even exacerbation of disorder in some circumstances. Then we have MMF, which also gives us a range of side effects. Then we have cyclosporin and methotrexate. These are all approved therapies which are currently available. And again, cyclosporin is causing hypertension, not usually in children, but still there are other side effects which we are aware of, and methotrexate as well. So now we move on to the novel therapies or the treatment options which are now available worldwide. The first topical option is crisaborole, and this is available by the name of Uresa, but it is not available in Pakistan. It has been FDA approved since 2016, like more than 6-7 years. and it can be used as a steroid-sparing agent. Its mechanism is that it inhibits the phosphodiesterase, and it can be used even for kids or children who are less than 3 months or up to 3 months and older with a less than 40% body surface area. It has a mild side effect of burning or stinging, and it is a very good agent for little babies. Then we have the biological agents available, and we are familiar with the monoclonal antibodies. One of these which is available in many countries, that is dupilumab. It is available by the name of Dupixent. As I said that there is a disclaimer, there is no conflict of interest, but I wanted you all to be familiar with the current names and the therapies which are there. Dupilumab is the first biological monoclonal antibody which was approved by FDA in 2017, and is still unregistered in Pakistan. It can be used for moderate to severe atopic dermatitis of 6 months and older. It decreases the inflammatory response and skin barrier by again blocking the interleukin 4 and 13, which have a major role in the pathophysiology of this disorder. This is a dosage schedule. We do not want to go into the details, but it is available in 200 and 300 milligram subcut injections, and it is varied according to the age of the patient, ranging from 6 months onwards. This is one of the babies who they have given the example that there is a marked improvement in the disorder after application, after giving subcut injections of this therapy. Then we other monoclonal antibodies which are available, but they are still in the trial phase. Some of them have been approved, that are treculumab and nemolizumab, but some are in the phase 1, 2, and 3 trials. These are fezacunumab and lebrikizumab. And omalizumab is also available. It can be considered in refractory cases, but it doesn't have a strong relief of the disease. It has shown up to 50% reduction in the clinical features. And there are few case reports of estecanumab as well. Now, what are the adverse effects of these disorders? Obviously, no drug is without side effects, but the common ones with these are nasopharyngitis, headache, upper respiratory tract infection, conjunctivitis, and viral infections. And nemolizumab has similar almost side effects. Then we come to the second or rather third novel therapy which is available. This is a systemic therapy of JAK inhibitors. We are also using JAK inhibitors in alopecia areata and vitiligo, but atopic dermatitis has also shown that it gives good results in this disorder as well, as it's the name stands for that inhibits the JAK-STAT pathway. The phosphorylation of JAK-STAT is inhibited, which results in a blockade of the cytokine release. So it also affects the interleukin 1 and 13 signaling, and which is resulting in the dysregulation of the keratinocytes. This is another study in which they evaluated the oral JAK inhibitors as well as 3 topical JAK inhibitors as well, as we all are familiar that some of them are available, like tofacitinib and rexolatinib is available in a topical form, and then we have systemic as well. So the topical had shown improved atopic dermatitis among children. Then we have others, the oral ones, which are tofacitinib and 5 milligram BD dose has also resulted in a reduction in the SCORAD score, and baricitinib as well. Remember that these are more systemic ones are used in adults rather than in children. Topical are more used in children. So we need more studies to declare the safety and efficacy of these agents for our children, so that we get the best ones with less toxicity. Then we have oral phosphodiesterase inhibitor, which is apremilast. It is also being used for psoriasis and other disorders as well. So this also inhibits the phosphodiesterase, and there is increased level of cyclic AMP, and number of pro-inflammatory cytokines are then decreased, as it augments the activity of the anti-inflammatory cytokine interleukin 10. Another therapy which is in vogue is the microbiome therapy, and I hope you are familiar with this. Like, what are microbes? These are the organisms obviously on our skin, in our gut, and there is a thought that in atopic dermatitis there is an imbalance between these microbes, And by the term microbiome, we mean that it is the sum of the microbes, their genomes, as well the interaction with our system, our bodies, and the ecological system. So it has been put forward that multiple oral supplements like prebiotics, these are the roughage and the raw agents which we can get to ingest to improve our these probiotics. So this is almost the last slide. This is just a take-home message that we are all familiar with, the moisturizers. And we need to have a reactive treatment rather than proactive treatment.